Thank you all so much for joining our weekly seminar series for the Center for Healthcare Policy and Research. I like to give an intro for 1 second at the beginning because some of you come just for one talk that you're really interested in to make sure you know sort of what we do and sort of how we've been running these seminars. We have this weekly seminar time. We really do rotate amongst topics between policy, which we'll hear a lot about today, research, methods, and community and public engagement in general. So we're here every Wednesday at noon. Some attendees are taking this apart of a seminar in public health sciences. Some are our staff or our faculty in our center, and some are actually even taking it for continuing medical education credit if it's relevant. So we have a nice wide variety of audience. And today, in our seminar series to end the winter quarter, we are very fortunate and lucky to have Dr. Richard Pan join us today. Many of you know Dr. Pan. He is a pediatrician and former California State Senator. He is also now currently back with us at UC Davis as a senior lecturer in health policy and management in the Public Health Sciences Department here in the School of Medicine. Formerly, he was also at UC Davis, where he ran a pediatric residency program. Was vice chair of education in the Department of Pediatrics. And in his tenure in the California legislature, he was both in the assembly side and in the state senate side. And he was chair of many, many committees that are relevant for health, including the Senate Budget and Fiscal Review Subcommittee on Health and Human Services, and also as many legislative pieces. I'm not going to read every single one of them because there's many, but obviously involved in the Affordable Care Act, Medi-Cal reform, public health improvements, vaccine requirements. And he currently, in addition to his role at UC Davis, and now that he's no longer in the legislature, he's come back to UC Davis. He's also working with the California Healthcare Affordability Board, the U.S. Census National Committee on Race, Ethnicity, and Populations, and with the American Medical Association. So he has a national landscape in his new role, as well as with us here at Davis. So we are thrilled to have you back with us and to give a talk today and other opportunities to interact with you, Dr. Pan. And please do take it away. You can always put questions in the chat, but we'll have at least about 10 minutes at the end for a nice Q&A session with our speaker. Thanks so much for joining us.
All right. Thank you, Courtney. And it's great to be back here again at UC Davis. And, frankly, this is going to be a little bit of more of a biographical talk and policy talk than a research talk. I should mention just one minor correction. The the Secretary of Commerce has dissolved the National Advisory Committee to
Oh,
U.S. Census. So as of February 28th, no one is on that committee anymore.
yeah.
But one of the many actions this administration has chosen to do. So we'll just leave it at that. All right. So so again, thrilled to be here. I want to talk about medicine on a large scale, and that quote actually, oops, okay, quote actually comes from Rudolf Virchow, who is known as the father of modern pathology, and but he was quite the advocate as well. And he's basically said medicine is a social science, and politics is nothing else but medicine on a large scale. So medicine as a social science, as the science of human beings, has the obligations to point out problems and attempt their theoretical solution. The politician, the practical anthropologist, must find the means for their actual solution. So I sort of took that bridge and as a physician and decided to practice medicine on a large scale when I entered politics. I have nothing to disclose. We're not going to be talking about any manufacturers or commercial products, nor any investigative products as well, unless you consider certain policies investigative. So the objectives for my talk today are to explain why advocacy is essential in healthcare, identify policies that expanded health coverage here in California and frankly nationally, and relate how physicians can practice medicine on a large scale. So let's start talking about healthcare and advocacy and why that's so important. I'm going to start off with the World Health Organization definition of health, basically saying health is the state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So, this is a very important point that it's not just about stamping out disease, which is extremely important, but also about well-being and, the social well-being as well as the physical and mental. And so that's all an important element of health. Back in 2004, Grun actually published an article where he talks about the model of physician responsibility in relation to influences on health. And as we've been uh, learning more about the impact of social determinants of health, what is the role of the physician in all of this? Certainly we are involved in individual patient care. We can involved in access to care and availability. We may also address direct socioeconomic influences. So those are you call it classified as domains of professional obligation. And then there's of course what I call the domains of professional aspiration. So perhaps not professionally obligated, but we should consider those broader socioeconomic influences and global health influences. So it's more than just the individual patient care. There's also we have larger responsibilities. Now, I'm a pediatrician, so of course I have to also quote Abraham Jacobi, who's considered the father of American pediatrics and one of the first presidents of the American Academy of Pediatrics. And he said, "It's not enough, however, to work at the individual bedside in the hospital. In the near or dim future, the pediatrician, he's of course pediatrician, is to sit in and control school boards, health departments, and legislatures." She is the legitimate advisor to the judge and the jury, and a seat for the physician in the councils of the republic is what the people have the right to demand. So basically, calling upon physicians to basically not just practice medicine and even advise, but actually hold positions in legislatures and other types of positions as well. One of the things that one of the things I also want to just mention before I get is that um, when you look at the mission statements of our various professional organizations, right, they're about, the art and science of medicine, but also about the health of the public. So I think one of the important elements is we're thinking about the role of health professionals and, as being a physician, I tend to talk more about physicians, but it's not just about providing high quality healthcare to people, right? I mean, certainly that's an important part of our role, but those mission statements are also about the health of the people, right? So, we do have responsibility to be sure that people in general are healthy, not just the people who are coming to see us, and not just about delivering high quality, accessible services. I do want to talk about the Richmond Kolachek model for public policy. Julius Richmond was a pediatrician, sorry, another pediatrician who was actually Surgeon General under President Carter and also Secretary of Health. So he was the one who established the Healthy People 2000, Healthy People goals. Every 10 years we do those. He's the one who first started that, and he and Kolachek developed this called Model of Public Policy. And so they said there's three elements that are important in terms of shaping public policy. One is the scientific evidence. That's something we're all very good at here in academia. We do a lot of research, we collect data, and so forth. That helps define problems. Um, but you also need the social infrastructure, the systems in place to support a solution, and to a certain degree, some of us get involved in that too, right? We propose solutions, systems changes, and so forth. But the place where you generally lack when it comes to shaping policy is political will. How do we build the political will to lead these to change? There's certainly many examples. I will pick, one example is high quality preschool, which is not a health example, but there's strong scientific evidence, there's a social infrastructure, there's a political will issue, right? So it's been brought up many times. Interestingly enough, uh, if you take from a political lens, there are two states that have actually had the political will to try to push that forward. Both red states, Oklahoma and Georgia, right? And it's interesting. A blue state like California has not yet been able to succeed. So it's not merely where you are on the political spectrum. It is about how do you build that political will. So so I'm going to talk about my career, a career in medicine on the large scale. And for all the students who are listening, I remind people that, it's usually when I'm introduced to people start rattling off all the things I've done and my positions I've held. That when I started off, I was a student just like you. I was sitting in a chair in the classroom, right? I was in, whether it's medical school residency, getting my MPH, right? One thing I do want to just mention, sort of dating myself. So basically, I graduated medical school in '91. When I was doing my residency, we were struggling with a lot of issues in healthcare then as well. The Clinton Health Plan came out, I think, in '93. I actually got to listen to Hillary Clinton give a pitch to the speech to the AMA about that. We had numerous reports. Here's a cover letter of GAO about the uninsured population, and it seemed like we could never seem to bring that down. The uninsured population actually was continuing to grow a bit, but just like we were struggling, right, as a country to try to address that. So for quite a while, actually. Um, so in some ways, sort of getting jumping to the conclusion a little bit, and we'll talk about the journey. And of course, being a pediatrician, so as I said, I came to Sacramento in 1998, so that's sort of when ended this chart, and we're now in 2004, but this is gets up to 2002, and so I like to talk about the journey of how we got. As a pediatrician who got active in a variety of different things, which we'll talk about, how we got to the point where the uninsured rate for children, which was at almost 14%, got down to 4.2%. All right. So, and actually had been sitting at around the mid-teens and upper teens for actually, it was in the upper teens for decades. And so what happened in that period of time? So I like to talk about my personal journey is from the micro to the macro. I was a biophysics major in college at Johns Hopkins. So my first goals, career goals, when I initially, I wanted to be a doctor and I wanted to discover the next great cure. And I went to Johns Hopkins to study biophysics, and we did research on gene expression, and we certainly need people to continue to do that. Ended up in a detour because a grad student at Penn, actually at UPenn in Philadelphia, beat me out in my research project, and I had to find something to do for the summer. So I ended up working as a student research center at the place called the Center for Hospital Finance and Management, which was led by Jerry Anderson back then and still led by Jerry Anderson now, a well-known health economist. I think some of you might have heard his name. Got my first exposure to health policy, worked on a book on the history of academic health centers, but they were studying things like prospective payment systems for the Medicare system, Medicare, et cetera, and got exposed to a lot of that. Went to medical school at the University of Pittsburgh, went back to the lab briefly, and then ended up applying in my second or third year. We actually had a summer break then. I know nowadays many medical students don't. Applied for two things: an NIH Summer Research Fellowship and to the U.S. Public Health Service Co-STEP program with the National Health Service Corps, and got both. And everyone told me, go to NIH, go to NIH. And of course, it'll look good, and it's a research. And my dean of student affairs, who interestingly enough was an infectious disease physician, said, I think you should go to York, Pennsylvania to work at a community health center. And I took his advice and ended up going there and learned a lot more, and actually got exposed to a lot of issues around social determinants of health before there was even a name. I said, I'm sure the name was around, but I wasn't aware of that name, right? So learning a lot about the community there. I actually went back with the co-step in my fourth year in Covenant House in Philadelphia. And the reason I mentioned that is, in case anyone wonders why I did vaccine legislation, everyone remembers in 1991 in Philadelphia, there's a very large measles outbreak that happened that actually killed about 9 kids and affected I think over 1,000 people. And so I happened to be there and got to see measles for the first time. Ended up did my residency at Mass General in Boston, did a community clinic and a community health center, established community peds rotation, was chief resident, then went off to Children's Hospital where I did a fellowship in general academic peds, where I studied physician career choice, but also community pediatric child advocacy, and got my MPH. So now, aside from all that fun doing all the training, one of the things that I got an opportunity to do when I was in Massachusetts doing my residency and fellowship was a couple things happened. One was is that anyone remember Newt Gingrich and the Contract with America? So yes, so at that time it was under President Clinton, and the Republican Congress actually proposed to block grant Medicaid. And there was a front page story in the Wall Street Journal about how the new Republican Congress had come to deal with the AMA for in exchange for things like some Medicare reforms and national medical liability reform, and exchanged but also proposed to block grant Medicaid. So my state medical society, Massachusetts, actually decided to convene to put together a task force to look at this proposal and say which way will our state medical society go on that. And I actually got appointed to that task force. I was one of 6 people on there. And we talked about the proposal, including the block grant. And when it got back to the block grant, I was, as a pediatrician, I was the only one who really took care of a lot of Medicaid patients. And I said, well, actually, this is terrible for all these reasons. So all the other stuff, maybe some of the other stuff is good, but this is terrible. And the group actually went, oh, interesting, because they didn't take care of a lot of Medicaid patients. And they said, okay, well, maybe that's a bad idea. So we actually recommended to oppose that, and the medical society came out and opposed. And Ted Kennedy went and told all his colleagues that while the Republicans claimed, well, the doctors support the proposal, he said my doctors oppose it. So that helped stop that proposal. Now, the other thing that also happened in Massachusetts was in 1996. Representative, the chair of their assembly, I guess they didn't have assembly, House of Representatives Committee, the equivalent assembly in California, came to the medical society and said, you know what? I want to try to expand healthcare coverage for kids, and there's an opportunity to do that, and I want to fund it through a tobacco tax. Are you on board? And we said, yes, we're on board, and then helped get the business community on board as well. That proposal actually got through the legislature. Governor Weld at the time was running for U.S. Senate. He was terming out. Republican governor vetoes the bill because of the tax increase. We actually override his veto, which is pretty hard to do. And then Senator Kerry, who didn't defeat Weld for his reelection, said, "Hey, sounds like a really great idea, right, in my state? Because after all, anything that can override the governor's veto must be pretty popular." So he essentially proposes it in the U.S. Senate. Ted Kennedy picks it up because he's kind of more of a heavyweight in healthcare. It was Republican Senate. He went to talk to his friend Orrin Hatch. And then it went from a Kerry bill to a Kennedy Kerry to a Hatch Kennedy bill. And then that became a state children's health insurance program. So I got to be in at the very beginning there at the state level. Sorry, I said it was inspired by the 1996 legislation. And so SCHIP itself was actually the largest expansion of healthcare coverage for, in general, since the passage of Medicare and Medicaid, of course, specifically targeted to children. And again, through a federal tax on tobacco. And those actually, the actual bill that Kennedy and Hatch didn't make it, but it was folded into the Balanced Budget Act of 1997. And then here in California, it became Healthy Families, if people remember that. And it actually reduced the uninsured children in the United States from 10 million in 1997 to under 5 million by 2012. And of course, SCHIP is still around. It's now called CHIP. It was renewed CHIPRA in 2009. Well, after I finished my fellowship training, actually, interesting enough, one of my last papers I had to do for my MPH program was because there were several options states could take. I actually wrote a paper about which option I think would be best for a state to pursue, and in the SCHIP program. I came to UC Davis to start a child advocacy training program, which called Communities and Physicians Together, and of course in doing that, one of the things I had to do was model for the residents, for all the students here. You probably sometimes might wonder, well, my professors, talk about a lot of things. Do they actually do it themselves, right? And so, of course, I had to model that for my residents. As a result of that, became active in a variety of different organizations. Became president of the County Medical Society, became vice chair of the American Academy of Pediatrics in California, got appointed to the First Five Commission in Sacramento for early childhood development. Actually, currently I'm chair of the United Way Board, but I was eventually on the United Way Board, and we all worked on trying to expand healthcare coverage for children. In fact, actually started and founded a not-for-profit, Healthy Kids, Healthy Futures. As a result of that, so there was a collaboration between the medical society and the hospitals, UC Davis included, and also many other child advocacy groups. And so we created a 5-county children's health initiative. Actually, Santa Clara was the first one to do it as a county. But we created one of the few multi-counties. And in fact, we're the only multi-county children's health initiative that didn't have a single health plan. There was another multi-county, thanks to Partnership Health Plan. Because they covered multiple counties, they put all the counties together for their children's health initiative. So we put 5 counties together in 2000. Well, started with 4 in 2003. Foster joined in 2007. Funded health, dental, vision coverage to kids who did not qualify for Medi-Cal Healthy Families up to 300% of federal poverty. And it was funded by a combination of the first five commissions in each county, foundations, health systems, and plans. One of the things I just keep note of, if you look at those counties, they're not all like, progressive counties, right? Some of them are fairly conservative in terms of their politics, and thankfully, most of the kids who don't qualify were actually undocumented, but we were able to actually build this coalition together and have each of the counties participate and actively fund healthcare coverage. And so we helped over 65,000 children. We did disband in 2010. So what was happening in 2010? Well, the Great Recession. And so with the Great Recession, a lot of the foundations, their money was starting to dry up. Obviously, we we're struggling with state budget deficits and local budget deficits. However, by 2016, the state of California actually expands Medi-Cal coverage to all low-income children. So the mission was actually finally accomplished at the state level in 2016. So even though we had to disband the initiative in 2010. All right. This leads us actually to the Affordable Care Act. This is President Obama. He came to speak at the AMA. Actually, I was there at the AMA. And I do want to make note. I mean, different people have different opinions about the AMA, but when it came to the Affordable Care Act, the AMA was actually behind the president, practically the entire journey. Now, I will tell you, behind the scenes is a little more challenging. And in fact, part of the story is that remember I talked about chip and how important it was and all the work we did in Massachusetts to get it passed, and when it went to the federal level, um, so I was actually a resident, a delegate to the AMA. The AMA at that time was not willing to actually support SCHIP. They didn't oppose it, but they didn't support it. There were many of the delegates thought it was a expansion of government-funded healthcare, socialized medicine, probably not a good thing. And so the AMA was actually neutral on that. Uh, I was actually fairly upset about that and said, okay, well, I have a choice here, right? I could say, well, AMA doesn't represent me, walk away. However, it is the main organization representing physicians, at least. Or I could stay in the organization and try to change the policies. And so over the next 10 years, it eventually, got policies in to the AMA. And so when the ACA showed up, they suddenly looked at their policy manual and said, "Oh, I guess we have to support this," because we had changed so many policies that basically were in line with the ACA that the leadership basically found themselves, even though there was a faction of people who were opposed, basically said, "No, we have to support this because that's our existing policy," and in fact had to fight off many efforts to change some of those policies to try to get the AMA in opposition. So, but if you looked at during the passage of the ACA, every time you saw President Obama speak, who was standing next to him was the president of the American Medical Association, right? And including all the various different iterations that happened as well. So, but certainly the ACA led to many significant changes, and I'd like to say that I had played a bit of a role in the AMA actually supporting the ACA. Now, one of the things that also happened is that we talked about 2010 and the Great Recession. So here I was at UC Davis, starting our Children's Health Initiative, working through organized medicine to get support for the ACA and so forth. In 2010, of course, we had the Great Recession actually started hitting probably a little earlier than that, and finally got so frustrated that the state couldn't pass the budget on time that I said, well, you know what? Now this is background. I am a child of immigrants, and I grew up in places where I never saw anyone who looked like me in elected office. So this idea of being in elected office was completely off the radar for me growing up, and even for most of my life. But I got so frustrated with what was happening in the legislature at that time. They couldn't pass the budget on time. Remember that? Clinics literally closed because they could not meet payroll because they would be paid in IOUs. And I was trying to, through my role in the United Way, I was trying to get some of the banks to help provide loans to them to keep them afloat. But there are certain banking regulations that made that very difficult. And so I finally said to myself, I'm not willing to throw my hat in the ring. How can I complain? Minor little problem. I lived in this district called Assembly District 5 at the time, and so I lived in that Sacramento portion over there. But as you can see in this description, this is a district that is a safe, that last line, safe Republican district. So I'm a Democrat. So this is nonpartisan talk, but just, the elections are partisan. So I just got to mention that. So most people, first of all, thought I had no chance of winning. And that's what a logical pundit would say. In fact, actually, when I first started, even the Democrats didn't want to run me because they said that only a white male could win in this district. You can see there's only 7.6% Asian. But I still managed to win the primary, and then in the general election, actually ran on basically saying that we need a problem solver, and defeated my opponent, who was actually a longtime political operative. He actually was the author of Proposition 8, which had won in that district just 2 years before. So it was a winning. So technically, it was a winning thing for him to have authored Proposition 8 in this district, but I won, and that's how I ended up in the California state legislature. I will point out that I was the only Democrat to take a Republican seat in any state or federal legislative election in the whole country. So no congressional seat, no other state legislative seat that election. I was the only one. So to flip the seat. So you can tell it was a challenging race. So I head off to the state capitol, leave UC Davis. And I sort of, without going through all the details, we'll talk more about some of the specific policies. But I like to say, when I came in, California's the ninth largest economy in the world. When I left, it was the fifth largest. Our state budget went from a $28 billion deficit when I came in to a $3 billion reserve. Things seem to have gotten worse after I left, though. And then the uninsured rate, not only 0 to 64, actually in California was at 21%. A little higher because of the Great Recession. Generally is in the upper teens, and actually down to 6% by the time I left. And I also have to mention the school vaccination rate went from 90.7% to 94%. Actually, it was a little higher before COVID, so that's a slight slippage because of COVID as well. But so I'd like to say accomplished something when I was during those 12 years. So let's talk about the Affordable Care Act. You might not be able to see all the little details here. This is a chart from the California Healthcare Foundation, sort of describing that when the ACA was passed, right? All the different things that need to be done. So this is in 2010. All the different things that need to be done to implement the ACA. So there was the Medi-Cal expansion portion, right? There's establishing the exchange, or staying up, whether it's joined the national exchange, or so that was covered California. There's also the various reforms that, while in federal law, in order for the state to be able to enforce, or state insurance commissioner, or the Department of Managed Healthcare, we'd also need to put in the state law as well. So there was a lot of work to do to implement the ACA, even after its passage at the federal level. So, I just had, interesting enough, after working to get the ACA passed, I happened to be in the legislature just in time to do implementation. In fact, during my second term in the Assembly, I was chair of the Assembly Health Committee and authored legislation to actually enact many of the health insurance reforms into state law so that we can have state enforcement. That was including a ban on discrimination by pre-existing conditions, essential benefits established, the annual lifetime limits and lifetime coverage caps were abolished. Children covered till 26 was already done by the time I got there. The individual mandate for health coverage, we'll talk about that later. That was not put into state law initially, right? Health Covered California was established as well as a state exchange. We actually set up a bit differently than many other states or the federal level. Where it's an active, so most importantly, it's an active purchaser. So if you're a plan, you can't just sign up for Covered California. Actually, you have to negotiate with them, and they will. And we actually divided California into 19 what's called rating regions, or healthcare markets as well. And then, of course, we had the Medi-Cal expansion that to all low-income individuals under 100% of federal poverty level, unless you weren't documented, and a few other things. But we address that later. However, I'd like to point out we've gone beyond the ACA during my time in the legislature. So as I mentioned with the children in 2016, we actually expanded the Medi-Cal to undocumented children. In 2016, the voters passed Proposition 56, which was a tobacco tax that funded increased Medi-Cal provider payments increased residency positions, and loan repayment for underserved communities. So that was really important to try to get that out. Actually, interesting enough, when the proposition was initially passed, the Governor Brown actually tried to take that money and not increase funding for Medi-Cal, and managed to push back. So we got the increased money to do all these things. 2019, we expanded Medi-Cal to undocumented young adults, not just kids, and then as well as actually eliminating premiums. There were some premiums for families over 150% of federal poverty level. And then 2022, we passed expand to undocumented people over 50. And then before I left, actually, although it didn't take place until 2024, we also passed exclusion of Medi-Cal based on immigration status, so that anyone who's undocumented starting with as of last year actually could enroll into Medi-Cal. State funded, of course. There was no federal match for that. And ultimately, what that resulted in is a decline in the uninsured rate, so an increase in Medi-Cal. So as you can see, this is a graph based on the American Community Survey. You can see 2010 is when the ACA essentially came into being, but implementation took time later. And so we could see the impact of first the Medi-Cal expansions, and then also our additional work as well in terms of dropping the uninsured rate. I should also mention that while this shows Medi-Cal and uninsured, we shouldn't forget about the role Covered California played as well in reducing the number of uninsured as well. And frankly, basically stabilizing the individual health insurance market. 2016, things got kind of interesting. Donald Trump became elected president with the goal of upending the ACA. And while he and the Republican Congress were unsuccessful in actually repealing the entire ACA, they did do a variety of different things to try to destabilize particularly the healthcare market, such as Covered California. So one is they zeroed out so it's technically they didn't take away the mandate, but they zeroed it out. So there was a penalty for not being insured if you could afford it, and basically they turned that penalty to zero. They also did some different other things as well to basically increase uncertainty in the healthcare market, and which caused insurance rates in Covered California and the healthcare markets to increase. So at that time, I was chair in the Senate and also in the Budget Subcommittee for Health and Human Services, and so basically worked on restabilizing our healthcare market. So we actually passed a state individual coverage mandate in 2019. Not an easy lift because, frankly, that was the least popular part of the ACA, right? And so had to get, the governor was in support, but had to get my colleagues on board to do that so that we could ensure that we don't have, all the sick people in the plans and none of the healthy people, right? We also recognizing that because we had this coverage mandate, we also funded Covered California premiums subsidies to increase affordability, including particular households at 400, 600 federal poverty level. If you recall, the ACA provided tax credits, refundable tax credits for people up to 400% of the federal poverty level. But you had a lot of people who at the 400, 600 who basically really don't make enough money, especially thinking about here in California, the cost of living being much higher. And especially if they were in we had the age bands, if you were in the 50 plus age band, your health insurance got pretty expensive. You had no help. So we actually provided premium subsidies to help bridge people. We actually, by stabilizing the Covered California market, we actually got the average premium growth for 2 years in 2020 and 2021 of being less than 1%. So lower than the inflation or the GDP increase during that time, thanks to our efforts to stabilize. And then finally, because of COVID, we had the American Rescue Plan in 2021. Well, thanks to Biden. And what that did is it actually capped the marketplace insurance premiums at 8.5% of household income without the 400% of federal poverty limit. And so that actually helped free up some money for us that we were using state money to help bridge it. That now helped. Now the federal government was doing that, and that was extended in the Inflation Reduction Act until this year, 2025. So one of the things that we're really facing this year is that if those premiums caps are removed, are not extended again, then we're going to have people who are over 400 federal poverty level are probably, going to drop their health insurance because they're going to think it's unaffordable. And the question is, will this, what can the state do? We weren't subsidizing it as much, of course, as the federal government by keeping the 8.5% cap. And but certainly that's something that state will have to think about. Do we try to resume those subsidies, especially given the current state budget picture? So so I think that as we talk about the uninsured rate in non-elderly Californians, you can see here that this is from the California Health Care Foundation 2020, published 23. They made note that in 2022, we had the lowest uninsured rate in California in its history. So that's when I left. So this chart again goes from 2013 to 2022. So that's kind of like when the ACA really started to kick in terms of implementation. And of course, being a kids guy, I have to show this chart. So this is health insurance coverage for children 0 to 18 from 2008 to 2022. So many ways to think about it. I came in the legislature in 2010. And so here we are. And actually, children's coverage for children, even though we at that time already had healthy families, was still the uninsured rate for children was still higher than the national average. And by the time I left in 2022, you can see we essentially got the uninsured rate down to around 3%, and it's lower than a couple percent lower than the national average. So I like to think that I accomplished something in my 12 years in the state legislature with the various policy activities that we were able to move forward. So moving forward, so as mentioned in the introduction, I'm now in the Office of Healthcare Affordability. So we're trying to figure out, that was one of the pieces of legislation I worked on before I left, and I was appointed as the Senate member on the office board. So we're working on trying to figure out how we can continue to reduce the rising costs. One thing I should make note is in the ACA, in general, healthcare costs were our healthcare spending was actually increasing faster than the GDP. But since the passage of the ACA, if you smooth it out a bit, it's kind of in line with the growth of the GDP. However, we'll see what the more recent years will show, because obviously there's been a big increase this past year. One of the things that I think, though, is that while that sounds great, and the healthcare is not consuming an ever larger portion of the GDP itself, that the GDP disproportionately, we're seeing the health disparity, actually it's a wealth disparity, has been increasing, right? And so what that means is that for sort of ordinary Californians and ordinary Americans, healthcare is still growing faster than than their incomes, right, and their compensation. So while we've gotten it to be more in line with the GDP, a larger and larger portion of that GDP is going to essentially the very wealthy people, and so that's still growing faster than most people's income. I should also mention is that I worked on the CalAIM, so we got a waiver to help do social determinants of health, including housing, since homelessness is a big issue in terms of one of the top issues here in California, and affordability. And so I happen to chair the United Way board, as I mentioned. So we've been involved actually as the United Way board on CalAIM. Those waivers actually expire, I think, in 2026. So but that allows our Medi-Cal program to actually fund things like housing, other types of social terms of health activities. So hopefully we can demonstrate how well it works, and we'll see whether this administration will allow us to continue that waiver so we can continue that kind of work. But as we talked about in the beginning, healthcare, those of us, health is more than just healthcare, right? And so as we look at our oftentimes our healthcare programs, and we can argue whether they should be funded through Medi-Cal or through maybe social service agency directly, this is a way to get matching federal funding to expand the amount of funding we have at the state level. Of course, despite this 30-year journey, I can say 30 years, right, from the 90s, early 90s to today, or even 35-year journey and trying to expand healthcare coverage and watching the uninsured rate going down. We have a new administration there with a lot of different things going on. They haven't even been in place for 2 months yet, and we're seeing research funding blowing up. We're seeing uh, diseases that we thought we had eliminated potentially coming back, like measles outbreaks. And also, we have a proposal to at least a congressional resolution that would essentially, although it doesn't say explicitly, implicitly could cut Medi-Cal by or Medicaid by almost $880 billion. And reduce Medicaid. So we'll see where we go in the future, and what kind of disruptions may happen. But hopefully we can continue to hold the line as we said, gotten our uninsured rate. I mean, it was supposedly an unsolvable problem when I came in the legislature, and hopefully we've actually showed we can solve it, or at least get it way down. So I do want to conclude my talk in the remaining time to talk about learning to practice medicine on a large scale, as I said. So, as I said, I started off sitting in the I guess the chairs are now you're in front of the screen because we're virtual, but it's like just like everyone else, and when I was a student and resident. Um, so what are some of the things that have helped me in my journey to practice medicine on a large scale? So one I have to say is that being involved in my professional associations, right? My specialty society, the American Academy of Pediatrics, where I eventually became the vice chair for the state. My role in the AMA, we talked a little bit about that, how I was as a delegate in their House of Delegates, um, uh, fought to be sure that the AMA supported the ACA, and also my role in the CMA as well. I think one of the things that I do mention for those of you who are in sort of the medicine side of things, but I think it also applies to other health professionals, is that by being part of your professional association, one of the things that you do is you get to, first of all, interact with people in your own profession, and sometimes what happens is we go on our careers, we tend to, the people we interact with tend to be narrower and narrower, right? So, I mean, I'm an academic general pediatrician. So, I mainly interact clinically with other pediatric people, or at least pediatric specialties and so forth. But versus, let's say, in medical school, I got to interact with a whole variety of people in a lot of different places. Right. So I think being involved in professional associations gives you an opportunity to stay in touch with the broader breadth of people in your in medicine or in your profession. And then the other thing is that generally many of these associations do have people who are government relations folks, right? The lobbyists. And if you're a member, they work for you. And so you can learn a lot from them. And also, they're usually interested in, for people who want to be engaged in teaching you a bit about like how things work in the state capitol or in Congress or in local government. So I do tell people when people say, I'm interested in policy, I said, first of all, join your professional association, right? The other thing I actually also advise people that, especially our trainees, is that obviously you're very busy learning whatever whether it's medicine or nursing or whatever else you're doing. So you're very busy doing that, and I tell people, well, pick a topic that a health policy topic to follow closely, right? Nothing big because you don't have time. Something small. So in fact, actually, interesting enough, when I was in residency, I was particularly focused on, as a health policy nerd, on financing graduate medical education. Right? It's a sort of a technical topic, but but because I was following it and monitoring that back then PubMed before Google, right? Any paper that was published about this topic and so forth, I became quite knowledgeable about it. In fact, some people would even call me an expert. Not maybe not as much of an expert. Some people more active in the field. In fact, actually, my professional society asked me to write their policy statement on financing graduate medical education. So actually, I wrote the first version of this, and then later became a contributor to a subsequent version of that as well. I've been invited to be by different places to be a consultant on GME funding as well. So you never know where that can take you. But I guess the thing is it's not so much that you do that because that's what you hope to land, but by taking one particular issue and delving deeply into it, it provides a model or a lesson about how to look at other things. You want to really look at it from a 360 point of view, right? Not just, the side saying like, oh, I'm for this thing and I only read the stuff that's for. You really want to understand the issue all around. And then that particular issue then helps you creates a model for you to say, okay, well, when I look at another issue, what are the different types of things that may come up as well? So as I said, pick a topic that you're interested in, shouldn't feel like work, and just start and pay attention, right, to it. And now with Google, you can every month or something, Google and see what else, see if anything new showed up about this topic. And the other thing is that I think many of us have this experience, especially in many issues, you start seeing I wouldn't say the same old names, but there's usually the community of people who are focused on a particular policy area is oftentimes not that large. And you may even, after you get to know their work, reach out to some folks and say, hey, I'm interested in this. And people are oftentimes interested in talking to you about their favorite topic. So uh, now, being again, as a community pediatrician, I say it's important to learn about your patient's community. So one of the things I did when I came to UC Davis, we created created a program to get doctors out in the community, applied a concept called asset-based community development. That's to look at how to better understand the patient's community. And we talk about, doing community tours and asset mapping and finding out what the resources are in the community. So I think that's really important because you're thinking about building political will. So going back to that chart about political will, to improve political will, you need to understand like where your community's at, right? So what's driving people? Is it the price of eggs or something else, right? So getting to know about your community and what the challenges people in the community face is a very important part about learning about political will. The other thing is actually developing those relationships. So certainly you want to develop intra-professional relationships through your professional societies. You also want to develop relationships with other people as well. So if there's something that you have common cause in, again, that's how you build political will, right, with people in the community. So, but I would also take the approach of looking, in terms of approaching people in the community, is really looking at call informal leaders as well as formal leaders. Sometimes we just look at the formal leaders, informal leaders, and also to make note of, to identify what I call assets in the community. Sometimes we look at communities and say, well, there's problems here, and not saying the problems aren't there, but also to look at what strengths there are and how we can build on those strengths. So there's a sort of a bit of a summary of my journey to practice medicine on a large scale. I, it's, and So hopefully that this gives you some ideas about what you might want to do and your efforts to practice medicine on a large scale. And again, really appreciate this opportunity to talk to all of you. And actually, it looks like we have the time for questions. I definitely want to hear people's questions as well. So thank you very much for having me. Thank you.
Thank you so much. Yeah, I was going to say, please raise your hands. This is great. I think we already have a question if you want to come off mute.
All right.
Yeah, go for it.
Hi, Dr. Penn. My name
Hi.
is Devesh. I'm a physician at an FQHC in San Diego,
Uh-huh.
and just really glad to have you here with us. I'm curious to hear your thoughts on what the trajectory looks like career-wise for physicians who are interested in running for elected office. Obviously, your career has been incredibly impressive, and I'm sure you have no regrets so far about what you've done. But there is this kind of long period that you need to lead up to get to a position where you can have some strong effect. And that for us includes the long medical and residency training in addition to all the community involvement, whereas certain other fields can get started off in a political career relatively sooner. So I'm curious if you have reflections on that.
Sure. So first of all, in terms of regrets for office, I will just mention that it was probably the worst financial decision I ever made. So it's not a regret, but I think we need to have full transparency about that. Given that our California legislature is full time and actually one of the best paid legislatures, but certainly doesn't match up even to an academic physician's career. actually more and more physicians are interested in running for public office, and I think that's a good thing because, frankly, for a while, I was the only physician in the California state legislature. Right, I came in. There was one other person there who was elected with me. She left after one term, couldn't stand it, left. I was the only one for a while, and then finally, Rambula came aboard. Now we have actually, I got one elected right as I was leaving, so we still have three in the state legislature. But it's not just about statewide or even Congress, and we do have a handful of physicians in Congress. I think if you saw Bill Cassidy struggle, you can see some of the challenges of being a elected official. And, with RFK Jr., you can either agree or criticize with his decision. The political imperative for him was actually to vote yes. So it's, sometimes you're caught in those types of things. We could argue which way you want to go, the doctor hat or the politician's hat, and are they how different are they or how similar they are. I would say is, first of all, of course, if you're interested in elected office, first thing you got to do is get connected to the community. I happened to already do that because of the work I was already doing. And by the way, I practiced in the FQHC before, and then during my time. So thank you for practicing at FQHC. Rah, rah. But really is getting connected to the community and getting people to know a little bit about your work. Now, I should also mention, despite all my work that I was doing in the community, when I first ran, my name ID on my first poll was essentially, it was 2% with a margin of error of 3%. So essentially it was zero, right? So just FYI, I was considered, I was on the United Way board, I was et cetera. And like most people still didn't know who I was. So but you should look at, for example, opportunities for like appointments. Like I was actually on, again, the first 5 commission was an appointment. So, and then that way people get to know you, including other elected officials, are elected officials as well. So you should probably look at that. The other thing you might also want to consider is that if you have someone who you really feel good about supporting, to be actually somewhat involved in their campaign, as well. And then the other thing is, you mentioned about the long run up, particularly for, health professionals and physicians who tend to have a lot of education, right, requirements and so forth. Yeah, that's a challenge, but at the same time, you do come in when you run as a doctor with a certain cachet, right? All right, because I mean, few people, let's put it this way, a lot of times people think people are running for office because they don't have anything better to do, and that's the best job they could get. They don't say that about doctors who are writing. Like they definitely, people understand, like, you're not doing it because you have to, or that you need a job, right? I mean, and whether that's really a fair accusation or, contention or not for anyone who's not, but clearly, a doctor is someone who is making a sacrifice to run. So sometimes you can get a little bit of extra jump from that, but you still have to get connected in the community that you want to run in. So you can't just be like, I'm a doctor, vote for me. Like, no, that alone isn't enough. So hopefully that's helpful.
Yeah, and Jeff.
Thanks for your talk, Dr. Pan. Really grateful for you sharing your experiences. I had 2 questions if there's time, and only 1 question if there isn't time. My 1 question is, if you were going to give advice for researchers, and that includes maybe students who are kind of interested in having research inform policy, what is the one short, sweet piece of advice you might give to researchers from the spectrum, from student to employed researcher?
Well, I mean, I think that one is actually to pay attention to what policymakers are doing or talking about, or what people are talking about, right? If you're talking about how do I make my research relevant to policy, right? So, what are the issues people are particularly struggling with? Is certainly one of the things, because those are the things that people are trying to find solutions to, right? So we talk about how we play public policy. You're trying to figure out how to get more data into that. But I would also say and that's why I said that we're really good at doing the data side. Okay, we can argue about whether we could do better, but it's political will side. So in many ways, I would say there's also as much work to be done in terms of taking the research that you have done. Suppose you did do, something that you think is particularly policy relevant, is actually figuring out how to communicate that to policymakers, right? So that they will, be able to take that information and use it hopefully in a constructive manner, right? So it's not just the doing the research itself. You got to communicate it to not only just the policymakers, but sometimes the general public as well. So learning how to interact with the press, right? And now with social media, that's always interesting as well. But so you know, you want to figure out like how do you get your work into the public discourse?
Yeah. And last question, I think maybe from
Okay.
Dr. Marson.
All right. Hi, Jim.
How are you, Richard? Oh, I'm so sorry. Oh, dang, I'm so sorry. I didn't mean to take the last question.
No, you're
So
fine.
yesterday,
Go for it.
thank you for everything that you've done. We were yesterday, Dr. Satyan and I were and a couple other members were down at the Children's Specialty Care Coalition downtown, which I know you've been a part of and presented at. How is it, we go, this is a little bit of venting. You go and we go to the legislators' offices and you think you're talking about an important issue, right? We were talking about the Prop 35 funds that are going to be left on the table for the first quarter for Medicaid recipients and a couple of other issues. And we would go into the offices and we would meet with interns that didn't know what Prop 35 was. They would be calling Medicare instead of Medicaid. And then I saw my neighbor there, who is a lobbyist for Google and I think Standard Oil, walking with the legislator down the hallway. And it just, I feel like, and there was 1,000, folks trying to talk with the representatives. But again, maybe this is a little bit complaining, but it's trying to get the voices, the attention at the right level. Is it paying the right level of lobbyists or whatever? And you even mentioned about this, the funding aspects, right? You admitted some things about they can get more time if they're bringing money to the table for the legislators. I don't want to misquote you on that, but
yeah, I didn't exactly say that.
Yeah,
but yeah.
I'm sure it wasn't like that, but it's.
So let me try to address. So first of all, while it may seem like, oh, I got stuck with the intern and the lobbyist got to walk with the legislator, that it meant that that my message was going to be lost and the lobbyist is not. That may not be entirely true, right? It may seem like from your point of view, but actually, let's put it this way. The person who has time, I realize that the person you talk to, right? And by the way, a lot of the staffers are very young. They're learning, right? So you might have gotten, I said, a fellow or someone who's trying to learn. That's an opportunity. By the way, they have more time to talk to you to better understand, and they will be making recommendations to the member. Now, you're seeing the lobbyist with the member, right? Like, oh, well, they get to talk to the member. Actually, sometimes, so first of all, we don't know whether that is that conversation actually had to do anything with what they're lobbying, because let's put it this way, the lobbying corps, they spend all their time there. We get to know them, so sometimes we're just chit-chatting. The other thing is that a good lobbyist, actually what they're trying to do is they may be trying to seal the deal, but they probably talk to a staffer first, right? And they're just trying to wind it up, right? Because usually with the members, you don't really have time to explain a lot, right? So what you do is you got to educate the staff, and then the staff explains to the member, and then the member goes and has to make a decision, right? And the staff will get a recommendation. So I don't know if that makes you feel any better, but actually I would argue that if you had the chance to talk to the member and went straight without talking to the staff, that you actually might have ended up with a worse outcome. I said worse outcome, but basically less ability to influence than you did when you had a chance to and I get it. The person was like, I don't, Prop 35, what's that, etc. But educating them. The other thing I also remind people, anytime people are meeting with a staffer and they're like, why do I have to meet with the staffer? I just want to meet with the member. I said, by the way, the most likely job for a legislator is a staffer. So just think about, you're talking to a future legislator and you got in really early. Okay. So that education actually is still valuable. I realize Prop 35 and things may be quite different by the time they actually are in the legislature, but you know what? You get to do some education there. So, yeah, no, I mean, I do think let's just be really direct. Contributing to someone's campaign does help with access. Okay. right? Because you want to people, so the people who got you there, you want to be sure at least you're listening to them available. That doesn't necessarily mean that we're not listening to other people as well. Okay, and uh, so I don't want to give the impression that, oh, well, if I didn't donate to someone's campaign, or even if I gave to the other person, by the way, who ran against them, that they won't talk to me. As long as you're a constituent, I should say, constituent, then they're going to want to listen to you, right? And hear you out. I do think that talking to staff is actually very much worth your time. And that person is going to, if you can get that person on board, well, I can't guarantee the member will follow the recommendation. There's a good chance, right? Because they're probably talking to you, and they're like, by the way, if that person's asking that questions, that means you probably got to them first. Now, which means that you got to put your stake into the ground before the opponents had a chance to, because they're like, oh yeah, I know that, and guess what? Yeah, that was a terrible proposition, wasn't it? And then you're like, oh great, now I'm in trouble. I got to turn them around. Versus like, I got someone I can teach from the beginning and get them like understand it from my perspective, right? Before someone else got to them. So does that make you feel better? I hope it does, but that's really what's going on.
Love it. The inside and inner workings.
Yes.
I know we're at time. I really wanted to thank you again for coming and speaking with us. And I wanted to make one plug for all of you who are still here. The Dr. Pan is going to co-sponsor or co-plan an event with CHPR and the Division of General Internal Medicine on evidence-based policymaking, most likely in the fall. So stay tuned. There'll be more to come from us. And thank you for joining today. And here's this information if you want to reach out. Thank you.
All right. Thank you. Thanks so much.